everyone, and welcome. I do apologise that we're starting a few minutes past the hour due to some technical challenges. My name is Sally Davies, and it's my pleasure to be here to host today's brochure meetup on contraception under threat. So just a few quick housekeeping matters before we begin. The meetup will last approximately 1 hour. I might allow us to run a little bit over, given that we started a little late. So in the first 20 minutes to half an hour, we're going to hear presentations from our panelists, and in the last half hour or so, we will open up the floor for discussion. So please do feel free to drop questions in the chat. I did just also want to note that Monica Casper has sent through her sincere apologies, and she is unable to attend today due to a family emergency. So I apologise for the change in lineup. So just to set the scene for today, we are living through what may prove to be a watershed moment for reproductive rights globally. In 2022, the US Supreme Court's Dobbs decision overturned Roe v. Wade, which ended nearly 50 years of federal constitutional protection for abortion. A rising pronatalist movement worldwide argues that declining birth rates represent an existential crisis requiring government intervention, catalysing policy proposals ranging from, for example, motherhood medals to redirecting family planning funds toward infertility training centres. Meanwhile, the dismantling of USAID has left millions of women and girls worldwide who relied on US-supported contraception facing millions of additional unintended pregnancies and thousands of maternal deaths in 2025 alone. However, this is really not a US story. These shifts raise a very important antecedent question for all of us. Just what kind of issue is contraception? It's rarely discussed as a health intervention, but rather becomes a matter of reproductive justice and women's autonomy on one side, or moral necessity, existential imperative, and demographic survival on the other. These framings determine whose expertise counts, whose interests and bodies are visible, and what solutions seem thinkable. So today we're going to hear from two leading scholars on the global dimensions of reproductive health, and I will just invite them to introduce themselves now, if you would. Françoise.
Hello, I'm Françoise Baylis, and I've had a long and enjoyable set of relations and interactions with the Brochet Foundation, and welcome all of you to this. And I hope it'll be an exciting exchange of ideas.
Thank you so much, Françoise. Choolwe, if you would.
Hello, good evening, good morning, good afternoon, wherever you're joining. My name is Choolwe Nkwemu-Jacobs. I'm an associate professor of public health in the School of Public Health. I'm based right here in Zambia, where I have keen interest in researching around areas on sexual reproductive health, including access and utilization of contraception. Thank you.
Thank you so much. I think we're going to hear from Françoise first for her presentation.
Great. So can I just ask people to confirm that you can see my slides?
Actually, I don't. Oh, yes, we can now. I can certainly.
Great. Thank you very much. So I want to start off by talking about the reality that we have here in Canada. And I'm going to be starting with abortion and segueing to contraception, though one might think it more natural to start with contraception and then imagining scenarios whereby that you might have a situation of failed contraception and faced with some decision making with respect to termination of pregnancy. But I think you'll see by the end of this presentation why it sort of makes sense for me to think about it differently, at least in a Canadian context. So the first thing that I want to talk about is the issue of access, because although the focus of our talk is going to be around barriers, you have to understand in the first instance, at least in a Canadian context, when access became available. I'm going to be talking about 3 different moments in time in the Canadian scenario, and I'll give a few more details, but this is just to say, big picture, abortion becomes decriminalized in 1988. So for many of us, that's relatively recent in the grand scheme of things. It's certainly in my teenage years that we're actually seeing this kind of shift. And I'm going to explain a little bit about that later in the presentation. This is really with respect to surgical terminations of pregnancy, because if you look at a medical termination of pregnancy, this actually only gets approved in 2017. And the reason that's really important is you're looking at nearly 30 years between when a technology was in theory available and adopted in a number of countries, not adopted in Canada. Meanwhile, we live in a country where, in theory, abortion has been decriminalized as an activity. So I want to talk a little bit about that. Why does it take 30 years to do what other countries that have more restrictive rules around abortion are able to do? And then I'm going to talk at the end about access to contraception. And you'll see there, it's really quite recent, 2024. So I want you to have those kind of dates in mind, and that's the kind of arc that I'm going to be following in this presentation. I also then want you to think about the barriers in really kind of broad terms. And I think that there's scope here for us to revisit some of these ideas at the end of the presentations in terms of generic conversations about where there might be similarities and differences between different countries around the world, between the global south, the global north. What are the challenges and where's their overlap? And where are we pulling in different directions? So I think one of the things that's really important, and I think Sally alluded to this in her introductory remarks, is what's happening around a certain kind of paternalism, if you will, that women are not being empowered to make choices about their own bodies. And where does that come from, and why is that still almost in its heyday? I think there's also an important place here to think about how that broad perspective might inform or empower governments in terms of the policies they adopt and the regulations that they put in place or the regulations they dismantle, what ends up in court, why it ends up in court, et cetera. So you've actually got a higher sort of policy level on top of sort of social sets of assumptions about how the world interacts in this space. At least in a Canadian context, and I believe it to be true in most countries, there are issues of access to facilities. Now, the reasons for those barriers to accessing appropriate facilities might differ. In Canada, a big issue is the urban-rural divide, but I think that's worth talking about, such that when you even live in an environment where you may not have barriers in terms of paternalism, you may not have barriers in terms of government policy, you might yet still have barriers in very sort of pragmatic and practical ways in terms of getting access to the services that you require. And then last, I think it's really important to recognize that even in high income, wealthy countries, cost can be a very significant barrier. And that's in large part in our country because of the age at which women are needing to access these kinds of services and resources, and the financial resources they may have available to themselves. So let me talk you through what I wanted to say with respect to abortion in Canada. It was, at the time I was born, illegal to have access to a termination of pregnancy under any circumstances except for the life of the mother. That law gets liberalized, at least that's the language that we use in Canada, in 1969. And what the liberalization means is that it moves beyond the physical life of the mother. So there are other criteria on the basis of which a woman could request a termination of pregnancy. But one of the things that happens with that liberalization is that in order to attend to concerns, and these were actually voiced, concerns that women would somehow use abortion as a form of contraception, as if that was a choice that women would make, that they would choose this, there were constraints put in place. And those constraints are quite significant in the history of abortion policy in Canada. The main constraint is that in order to have access to a termination of pregnancy, it has to be approved by a therapeutic abortion committee. That would be a committee with a minimum of 3 people, and they would be physicians ultimately certifying that, yes, this really is an instance of a threat to the woman's life or the woman's health. And that's where you start getting an opening up, if you really want to understand it in terms of liberalization, because depending on which abortion committee you went before, that committee could be quite liberal in its thinking and understand that it's not a good idea for an 18, 19-year-old university student in their first or second year who doesn't want to be pregnant, who isn't in a long-term relationship, et cetera, that this really would be a threat to their quality of life long-term. But if you didn't have that kind of a committee, depending on where you lived in, they might have a very narrow understanding of what would constitute a legitimate thing. So what you have is you still have the state as a barrier but not in terms of government policy saying no, but in terms of government policy saying yes under these conditions, and the conditions being quite variable across the country, and ultimately at the whim of who gets put on this therapeutic abortion committee. And most importantly, there's no requirement to set up a committee. So if you really do not want to, as an institution, provide that service, you just don't ever set up a committee. If you don't have a committee, you can't have a committee approve the abortion. And so you still have significant barriers, although there's been a massive change in the law. What's important in Canada is that in 1988, we get a Supreme Court of Canada decision, and the court basically says that this law, this liberalization law of 1969, is unconstitutional. And it's unconstitutional. Why? Because it violates our Charter of Rights and Freedoms. And so it actually represents a threat to the life, liberty, and security of the person. Now, what's interesting is that the court in our judicial system can make a decision that this law is unconstitutional. It can strike down the law. It can't write the law. And so Parliament then has the task of writing the law. They attempt to do so in 1990, and they're unsuccessful. It passes in the House. It fails in the Senate. We don't get a law. And what's important in Canadian history is no government has wanted to touch it ever since. It does not mean that it does not remain a controversial, contested issue in Canada. It's just that there's no political party that's willing to risk their capacity to succeed in an election on this issue. So they don't want this issue as the election issue, and so they're not taking it on. So one of the things that's important to know as a background in Canada is there is no law on abortion. It's not that we have a very permissive law or we have a restrictive law. We're a country with no law. Abortion is a healthcare service in Canada, and it's provided through a universal government-funded healthcare service. Doesn't mean there aren't still problems of access, but at least we don't have those legal barriers. I just wanted to put this up and share this with you because the decision I referred to, 1988, the Supreme Court of Canada, is largely the work of one person, Dr. Henry Morgentaler, and what he does, just so that you can appreciate what happens around fights and activism in this space, is he's a physician, and he actually defies the 1969 law. Why? Because that law, I've already told you, required you to have a therapeutic abortion committee. But one of the other facets of the law is that required terminations to happen in an accredited hospital. Dr. Henry Morgentaler opens a clinic, is not providing the service in an accredited hospital, and he is arrested in 1970. My mother was his nurse, and my mother was arrested with him. And one of the things then that becomes important is that you now have a legal challenge. And when he goes to court, he's acquitted by a jury. And the government doesn't like that. And they actually have a higher court overturn a jury decision. This has made for a change in law in Canada, that they actually introduced legislation to never allow the court, a superior court, to overrun a jury. So one of the things that I think is important is to show that one person can make a difference in terms of advancing practice and policy in this space. These are just some very quick stats, just so you understand. The majority of the abortions that happen in Canada now are prior to the first 12 weeks. Whatever your views are on termination of pregnancy, I think most people would agree it's better that it should happen earlier than later if it's going to happen. So that's considered a success, that we're having earlier terminations. What is true is that different clinics and hospitals can have different rules, and some obviously are going to be bringing in rules for later terminations of pregnancy. And that's because of all kinds of either local concerns or actually skill and ability. One of the challenges with respect to access to termination of pregnancy is people ultimately refusing to be trained to provide those services. And so again, then you need to think about what are the many ways in which you can have barriers. Late-term abortions in Canada are very rare, they're unusual, and typically those are happening because of some kind of genetic indication. There's some controversy around that and what constitutes a legitimate indication, and we can talk about that later on. But I think one of the things to appreciate is that last statistic. 1 in 3 women in Canada will have an abortion during their lifetime. And some of that will be early on, not wanting to be pregnant. Some of that will be for gender selection, which is also a challenging issue. And some of that will be because of family completion, that, you know, the woman is in a healthy, loving relationship, but they've had as many children as they are able to cope with or as they desire. I want to shift now very quickly to birth control in Canada. And the main thing that I want you to appreciate is that I've spent this time trying to say that abortion is not legally regulated in Canada. Abortion is a healthcare service available through a universal government-funded healthcare system, and that is not true for birth control. Birth control is not funded through our healthcare system. And this is in a context where many people have been advocating for a very long time that it should be. And this really comes back to one of the barriers I identified, which is around cost. And I just put up there some numbers for you to have some sense of what that costs. And many of you might think, well, that's quite manageable. It's not so manageable if you're a young person, perhaps a young person who's unemployed, and, you know, is unable to pay that fee. And that's just one of the many barriers. I mean, if you're a young teenager, there are places in which it would be very difficult. Some physicians might refuse to see you without parental consent, etc. What you see on the other one side of the screen is, in fact, the statement that was advanced by our government at a time when there was a lot of advocacy around making birth control accessible. One of the things I want you to appreciate is Canada, just as we are unique, one of the only countries in the world that has no legislation, we are unique insofar as we're the only country with a universal healthcare system that doesn't include contraception as part of that. And I think we need to ask ourselves a really hard question. Why is that? Why is it that we would not assist women in terms of providing them with contraception, but help them if they actually come forward and require a termination of pregnancy? Many people have been fighting for this, and eventually in 2024, which is quite recent, we had the Pharmacare Act that was passed. And one of the things that becomes important is our system is such that individual provincial governments have to then endorse or adopt. And we have a situation whereby 3 out of 10 provinces, 1 out of 3 territories have agreed to build this into their healthcare system. So now in Canada, a barrier becomes geography. It matters where you live, whether or not you'll have access to that. So I just want to end with a couple of summary slides. Medical and surgical abortion is legal in Canada. It's a regulated medical procedure. It's free to all patients in Canada. There are still barriers, which I've alluded to, and we can talk about those later. Birth control is free only in 3 out of 10 provinces and 1 out of 3 territories, and cost remains a significant barrier. 40% of pregnancies in women between the ages of 18 and 44 are unintended. Not all of these will end in a termination. Sometimes women will go forward and have those pregnancies, but we then need to really ask serious questions about what that means to force people to go forward in a context where they might have done otherwise if they had choices. It is costly to our healthcare system to have the policy that we have. It would be cheaper, and I'm just saying this from the point of view of a government, it would be cheaper to fund contraception than to have the system we have right now, where we will fund a termination of pregnancy, but not contraception. And I just want to end by saying the following, by way of summary. The cost to provide free contraception is less than the cost to manage unintended pregnancies. And access to contraception is essential for gender equality, and it advances women's health and reduces poverty. Thank you very much.
Thank you so much, Françoise. Lots to pick up on there, but I will wait until we've heard from Choolwe. Choolwe, could I invite you to the floor, so to speak?
Well, so I'm trying to have access to share. Sally, are you able to share from your end? For some reason, I can't see the
so
icon.
on our side, I've got a black screen for you, Choolwe. So I think are you trying to share from your screen, or have you had the Brochet Foundation share the slides?
Yeah. Okay, let me, I've got it. Let me share. Thank you.
Thank you, everyone. Great. Yep, I can see that coming on.
Alrighty. Okay. So allow me to just put it on a presentation mode. Yeah, and good morning, good evening, all. Once again, I introduced myself, and so I won't labor to say much more about myself, and that is who I am, Choolwe Jacobs, from the School of Public Health at the University of Zambia. So today, from my end, I thought I could share around particularly access to sexual reproductive health services in Zambia, the case of Zambia, and I'll focus mainly on contraception. I thought sharing a viewpoint from this end, the Global South, might provide insights on issues that surround access to services, particularly barriers. Now, giving a bit of statistics and the background, I'll speak through Zambia. Over the past 5 years, the country has made significant improvements in population health outcomes. And among those issues of maternal mortality, we have seen reduction from 398 deaths per 100,000 live births to in 2013 to 187 deaths per 100,000 live births in 2024. So for a country like Zambia, this is a significant reduction, because we are coming from as high as over 700 deaths in the past 20 years. Now, as you may know, issues of contraception as it relates to pregnancy and as it relates to contraception itself, I thought I could also share some statistics regarding percentage difference of births to women aged 15 to 49 in the 3 years before this survey that we just concluded, the 2024 Graphic Health Survey, which showed that among the births that we've had in the country in the past 3 years, 61% were wanted then, 8% were unwanted, and mystified were 31%. And as you know, when we think about contraception, really, I would not emphasize on this one because it remains critical to good health outcomes, particularly for women. But also to mention that contraceptive prevalence among all women in Zambia is at 40%, with 38% using modern methods, only 38% using modern methods. And use of modern methods among currently married women also, well, has increased from 1992 from 9% to 53% in 2024. But also I thought I could indicate that the total demand for family planning currently is 71%, and yet women that are using contraceptives at 53%. This means that if all women that demand for services would you have these contraceptives, would have prevalence of up to 71%. So I thought I could also highlight and share issues of access to contraceptives, some of the barriers. In this presentation, I'm gonna just share the barriers that we encounter. And I was thinking about all these barriers and thought of how best can I present these barriers, because we have quite a number that have been highlighted from previous studies, including studies that have been involved myself. So I want to walk you through the health system at the health system level. So in Zambia, over the years, we have evidence that has shown that women are unable to access contraceptives for a number of reasons at health system level. Some of the reasons that I've highlighted here include stockouts and supply chain challenges. So for most of our facilities, while women might have a preference or a demand for contraceptive, some of these products, we don't have them, the contraceptives, they are out of stock within the health facilities. But also there are issues of supply chain where some delayed delivery of these services within the facilities contribute to such challenges that we find. And all these challenges reduce access to contraceptives. And while in some cases we might have the contraceptives within the facilities, there is also limited method mix. The preferred contraceptives most times would not be found. I'll give an example of emergency pill, injectable pills. Most women might prefer injectable pills, but then these are some of the contraceptives. These are some of the supplies that are usually unavailable, and they are limited. But also we have evidence that has shown that the quality of counseling that women receive regarding contraceptives has been reported as a challenge. Service delivery environments remain a barrier, and some of these service delivery environments that I would refer to are issues of lack of privacy, especially as relates to adolescents and young, who sometimes voted to indicate that they feel into the service tells some policy they would prefer privacy, but the environment itself might not offer the privacy that most of our women would prefer. There's also the rural-urban divide that we have observed, and based on evidence, distance to the health facilities. While the contraceptives might be demanded for and needed, distance, and this is evidence that has been shown and reported elsewhere, particularly in low-resourced settings, the distance, just the distance to get to the facilities can be a challenge to accessing services, and women end up lacking in terms of contraceptives with the consequences that I've just demonstrated, including unwanted pregnancies, as well as increased maternal mortality or poor health outcomes. But also we have had, and this is all around the health system level, we have also issues of provider attitudes and bias. And this is more so for adolescents that have reported. In a study that we conducted among young people in higher institutions within Zambia, we found that young people were reporting to negate these services, especially access to contraceptives, because they felt the attitude that they were getting from the providers was not acceptable. And some of the reasons they provided were they felt they were being policed, and there was also a feeling that these services, and there was issue that these services really were not for them. But also we have an issue of poor attitude that has been reported by unmarried women, including women without children. These are some of the reports that we have received from the evidence that we have so far. And so with all these issues, particularly as they relate to provider attitudes and biases, they all lead to reduced equitable access for services. Now, I know this is kind of mouthful because the issues are quite enormous, but also I wanted to talk about the issues at community level. While there are health system level issues and barriers to access, we also have issues that have been reported through some interviews and studies that we have conducted, and have been demonstrated that myths and misconceptions around contraceptive use are barriers to access to contraceptives. Now, myths and misconceptions such as infertility by use of contraceptives, those are some of the misconceptions that come up. There are other issues and beliefs that women that take contraceptives are believed to be promiscuous, and all those issues, they come up at community level. But aside to myths and misconceptions, we see religious and traditional beliefs coming up as a barrier. Now, religious beliefs, as you may know, such as there are certain denominations or beliefs, religious, that will discourage women from using contraceptives. but also traditional beliefs where women that use contraceptives might be believed, as I indicated, related to misconceptions as promiscuous. All these are issues that negate or that hinder women from accessing contraceptives. I thought I could highlight the issue of gender norms that exist. We have also observed that for some settings within our country and some cultures, there's an aspect of women needing to seek permission from their spouses to access contraceptives, get permission to get, and all this is related to gender norms that women believe that they need to get permission to access services. At individual level, there are also other issues that we have observed and have been reported. The aspects of law knowledge and misinformation have come up as a barrier to access, as well as fear of side effects. And I want to indicate the youth-specific barriers I've indicated, that young people on their own have specific issues and barriers, such as access to these services, as well as, if I may say so. So, yeah, so this demonstrates that within our setting, the issues to access to contraceptive are quite vast, and they exist at different levels, and all these lead to inequitable access to contraception. But with all this said, we still have opportunities that I thought I could share and we could continue discussing over. We think that making these services, particularly as we have seen that young people are most affected and adolescents, Zambia has made efforts to ensure that we have youth-friendly corners that provide privacy to young people so that they are able to access. So we think that enforcing and enhancing these services, ensuring that they are accessible to young people, is an opportunity that the country has to ensure that contraceptives are accessible. Issues of integration of service. For a long time, we've had independent service points in the country. And over the years, Zambia has found the potential of integrating family planning services within existing service points. But the issue that we're currently battling with or trying to resolve is the issue of how do we do this best? When we talk about integration of services, these are some of the implementation questions that we have continued exploring and trying to find the best way to integrate these services, particularly family planning services within existing.
Oh dear, I think we may have momentarily lost Choolwe. So instead of charging on, oh, here we are. Choolwe, are you there?
Yes.
Yes, I'm so sorry. We lost you for a moment.
Sorry about that.
No problem at all. Just feel free to pick up where you left off.
Okay, I don't know at which point you lost me, but I assume it's existing opportunities.
Yes, it was a matter of seconds.
Yeah. So I thought I could end by talking about the existing opportunities that we continue exploring and trying to find ways that we can strengthen to support improved access to services. So I wanted to mention the need to strengthen government commitment and funding. I spoke about the stockouts stockouts of contraceptives. We think that the budget allocation by the government and funding towards contraceptive and family planning services could really support improved access to contraceptives. So allow me to end here, and thank you so much for listening in, and my apologies for the disruption. Thank you.
Choolwe, thank you so much. I think we were able to see your presentation perfectly in the end, so no problem at all. Okay, well, look, let's kick off the discussion. I'm going to give it at least half an hour, so we will run past the hour. I'll just start by offering an observation, and this is, I think, directed both to you, Françoise, and you, Choolwe. It strikes me that, well, for one, I think it's very interesting that both of you picked up on this question about the urban-rural divide as a persistent barrier to reproductive health care. And I'm really curious to hear from both of you about why that divide persists. And is it just a question of resources and infrastructure, or does it tell us something more interesting about whose access matters enough when these systems are designed? So happy for either of you to pick up on that question.
Choolwe, do you want to go first?
Yes, I can go first. Yes, that's a good observation. The issue of rural, urban, or residential disparities in relation to access to contraceptives really has been an issue over the years, where the rural communities or women in the rural settings have reduced or are disadvantaged when it comes to access to contraception. I hope you can hear me.
Yes, it's a little bit choppy, but we can hear you, yes.
Okay. So I was talking about the rural-urban divide. This, over the years,
We've just lost Choolwe momentarily. Maybe, Françoise, I'll just allow you to step in until Choolwe comes back online.
Yeah, so I think one of the things that's important in a Canadian context is some of the challenges with respect to access mirror the challenges we have with respect to access to all healthcare services. So those of you who maybe have been recently seeing maps of Canada, since somebody to the south of us wants to take us over, and maps are all over the place for the first time, you will see that Canada is a very big country geographically. And something that may not be familiar to everybody is most of the Canadian population lives within 200 miles of that border. So if you have this image of a country that's really quite vast in terms of its geography, but then you literally have a small ribbon of population, what happens is it's in those places that you're going to get access to healthcare services, partly just because there aren't physicians or hospitals or the kind of infrastructure that you need in the northern parts of the country. So that's one kind of barrier that's purely geographical, and it really then just maps onto challenges we have for the delivery of all healthcare services. Within that little ribbon, however, I don't want to pretend that we don't also still have challenges, and we have them because in many cases we do not have physicians available in smaller communities. So people, for example, would have to be able to travel. Believe it or not, we're having this kind of challenge at the same time that our bus services, which would take you between smaller communities and larger urban centers, are also experiencing shifts and not available. And that's one of the things that I think becomes important to appreciate, that the cost of some of these services isn't just the service itself, which in the case of termination would be free. In the case of contraception, there's a cost, but if you have to travel, that's a cost that's not necessarily going to be assumed by anybody. And so a lot of our challenges in terms of that is really having to do with systemic problems as opposed to anything narrowly specific to access to terminations of pregnancy. And the reason it also then spills over to contraception is you have to have a physician to give you a prescription for contraceptives. You have to have a physician in most provinces, with the exception of Quebec, to give you a prescription for MIFI, which would be the medical termination of pregnancy.
Thank you, Françoise. Choolwe, we just had Françoise jump in while you were resolving your technical issues. But yeah, do feel free to respond to anything Françoise has said, or pick up on
yes,
on your response.
Thank you. And quickly, just to mention that the issue of rural-urban differences really exists here in Zambia, and one of the from communities to facilities within the rural settings. While Zambia has made efforts to ensure that there's a facility within every 5-kilometer radius, we have noted that some of these settings start to that effort that is being made, and so it becomes challenging to access the service. but also to indicate that issues of skilled providers. For some facilities within rural areas where they're accessible, we have also noted that some facilities do not have skills to provide some contraceptives that might be preferred by these women. The country has also made an effort.
I think we've, apologies everyone for the connection. I'm just going to give Choolwe sort of 30 seconds to a minute to come back online just to finish her response. Choolwe, welcome back. Can you hear us, Choolwe? Here we are, we've got you, Choolwe. Hello, welcome back.
Oh my God, I'm sorry about this.
Don't worry at all, honestly, don't worry at all, please, no problem at all. Choolwe, maybe I'll just pause you momentarily I was just going to say, Choolwe, I might just interject if I may, and this is just a follow-up question for you really that will maybe allow you to unpack some of this content.
Yeah.
I was really struck in your presentation how the granularity of your research into the barriers that women face in accessing contraception, stockouts, myth and misconceptions, lack of privacy, specific dynamics with youth. I'm really curious to understand. Oh, I think we might have lost Choolwe again. Thanks for your patience, everyone. I won't continue the question yet. Also, maybe I will just allow us to run even a little bit further just to take account of some of these technical challenges. So we might go to 1:15. So please do feel free to drop questions in the chat as well, and I will try and pick those up in the course of our conversation. Maybe to keep things moving forward then, actually, Françoise, I'll switch to you and I'll welcome Choolwe back in when she comes in and we can pick up that question of mine. Françoise, it was interesting to me to hear about the political evolution of Canada's situation. Hello, Choolwe, welcome back. I'm just going to press on with a question for Françoise and come back to you, if that's okay, just to keep things moving forward. I was just going to say, Françoise, I was really struck by the sort of your story of access to reproductive health care in Canada is one about kind of historical contingency, that a lot of what people have access to is not really because of the positive commitment to reproductive justice and autonomy, but sort of because no one's been willing to fill a certain political vacuum left by the Senate defeat. And that in a certain sense, political avoidance has worked to women's advantages in some ways more than active legislation, well, in a way that active legislation may not have and may have produced, backlash effects and so forth. I mean, this is a bit of a leading question, but is that a stable situation? And there seems to be something uncomfortable about reproductive rights kind of depending on politicians' unwillingness to engage rather than on principled commitment. So I just would ask you to respond to that question, I guess, about this kind of historical contingency.
Yeah, I think that that's really important to appreciate, that you do not have a scenario that is grounded in a commitment to a certain set of values and an embrace, really, of what I think many would be arguing for in this sphere, which is that women are autonomous, responsible decision makers, that they can, in fact, make good decisions for themselves and their fetuses. There are contexts within which some of the decisions around termination of pregnancy actually happen with wanted pregnancies. And that's one of the things that sometimes people forget. And so I think one of the things to appreciate, and I think that really is why at very high speed, I wanted to give people a sense of the history, because I think it matters. Is it fragile? I think that in the near term, not so. And the reason I believe that is that even our Conservative Party, which is not in power now, has repeatedly said that they would not make this an election issue. And that has been the case now for close to 50 years. So even those who are actually probably wishing it were different they're not actually willing to make this an issue because they actually do believe that there are ways in which that would hurt their success as a political party. So I think we're going to see for a very long time no action on a political front to change the de facto situation with respect to termination of pregnancy. But it is exactly because you don't have this fundamental commitment to women that you have a policy scenario that makes absolutely no sense, right? Absolutely no sense that you would not say it's far better for women, it's far better for everyone, even on the spectrum of ethical beliefs, that you would try to ensure that you don't initiate a pregnancy rather than you find yourself in a situation paying for a termination of a pregnancy.
Yeah, and I think it strikes me that that this problem about appreciating the historical contingency of policy setups, that a lot of contemporary analysis treats arrangements as if they were designed to achieve their current effects and then proposes interventions accordingly. But actually, to what extent does this ahistorical thinking kind of limit what we can achieve? And what would it look like to design policy to enhance access that actually takes seriously how we got to this situation?
Yeah, and I think, again, just to underline that this was not sort of a very linear, concerted effort based on a set of fundamental values. And that's also why I really wanted to make sure that I put an emphasis on Dr. Morgentaler, because it is the work ultimately of one person. Now, over time, gets a lot of support, and that's from the medical community as well as the general public. But it is one person who's pushing and saying this is wrong, pushing and saying this is wrong, getting arrested, having his clinics firebombed, threats to his life. I mean, and it is just the persistence of one person to challenge a legal framework.
Thank you. Yes, and it's wonderful to hear about your mother being involved and see that intergenerational commitment to reproductive justice coming through. Choolwe, I'm going to just circle back to you at this point and kind of pick up the question that I started earlier.
Yes,
I was just really struck in your presentation about that nuanced analysis you offered about the barriers to access. As I mentioned, stockouts, myths and misconceptions, issues to do with privacy. I'm curious to hear, in your experience, to what extent do the programs funded by governments and other donors reflect those realities and try to overcome them? Or do you often find that they're designed around assumptions rather than evidence about what communities need, about how decisions get made? I guess I'm sort of curious to understand to what extent your research is then kind of reflected in the practices of people funding these programs or how those programs are implemented.
Thank you. Yeah, so you are right. I think there's a lot of granular in the issues, and sometimes within this space, you want to think how best can we pull and tackle one issue and see whether that one issue might solve the others. So we've observed that there's quite a diverse of issues that surround access to contraceptives at different levels, and this is why you saw trying to present in such a manner. But of course, I must also indicate that the government is making every effort. There's been significant reduction, there's been efforts being made, but these challenges remain. And whether these issues reflect the efforts that have been put in, it's a difficult answer to give, but probably not as quite, because the efforts are quite enormous. But I think where the gap lies is the issue of co-creation. And I think this is an area that we are trying to explore and capitalize on co-creating solutions. As can be seen, there are several factors and from different angles and affecting women at different levels, including young people. So the challenges that young people have, adolescents and young people, some of them might not be related to the order. So I think going forward, we need to explore as much as possible on thinking about co-creating designs, having the voices of the users, and thinking about what would best improve issues of access so that it's not just a top-down kind of approach. But I also think that we might need to be investing more on implementation science approaches. I know I'm getting in another angle, but thinking about what are we doing and to what extent is the efforts that we are putting in meeting our targets. Because I think with the minimal resources, with pull-off of funding, we might need to be focusing even on the minimal and capitalize on that. So yeah, I hope this answers your question, Sally.
Thank you. No, it's very interesting, and in some ways, actually, it's a nice on-ramp to a series, I think, of important and challenging questions from Dr. Feitshans that's come through now in the Q&A, where there's a question here about sort of, is this conversation effectively too narrowly focused on contraception and abortion? In terms of how we conceptualize reproductive health, which is the subject of the conversation in principle, is there a necessity for that conversation to be broadened? Now, it may be, you know, offering a hypothesis here, given the kind of political shifts and the discursive shifts and the threats to contraception and abortion. That's why they have become the kind of frontier of this conversation. But I'm curious to hear, Choolwe and Françoise, from both of you, do we need to sort of widen the sphere of activism, widen what is included in that bucket of reproductive health?
I mean, I would say up front, you know, reproductive health encompasses all of that, right? It is not just narrowly about the moment of, you know, being pregnant or wishing not to be pregnant. So reproductive health includes all kinds of activities that in fact don't promote the health and well-being of women writ large. And that's through the life cycle, whether we're thinking about menarche right up until menopause in some sense. And the reason I can say menopause and perimenopause is because we're looking at issues of cancers, for example, and are we able to identify them, et cetera. So one of the things that I think is fascinating here is to understand that breadth. But honestly, in a session like this, it would have taken the whole session just to name them. And I really mean that. And that's because they're complicated, for example, with things around gender affirming care. In my country and in other places, for example, recently with a lot of concerns raised around gender, there has been a threat to access to treatments for people who have transitioned, and yet they still have female reproductive organs. So for example, that in alone would be a topic worth talking about. A lot of my own work, for those of you who are interested, is actually around the issues of infertility. So actually the opposite kind of concerns here. How do we respond to people who are unable to have children, either unexplained infertility or infertility due to iatrogenic problems or environmental problems, et cetera? And, you know, what kind of resources should a country put towards supporting women in pursuit of the goal of becoming pregnant? So I guess those are just a couple of examples, and I just want to affirm that yes, reproductive health is much broader than what we chose to speak on, but we did try to describe that accurately in the invitation in terms of the overall project for this topic. But I think the Brochet Foundation would probably quite welcome suggestions for other topics in this space.
I guess in part, you know, the way I framed this collection of questions was really about sort of tactics and strategy, and how do we balance conceptually the necessity to capture that wide range of human experience in the definition of reproductive health, and yet, you know, maybe there's a sort of tactical advantage to like focusing the ethical conversation around these sort of hot button issues. And, you know, how do we balance that in terms of designing interventions, you know, pursuing activism, being, you know, either of the above. Choolwe, did you have anything that you wanted to add on that question of sort of how we conceptualize reproductive health?
Yeah, I think well said by my colleague, but just to add that, yeah, indeed the breadth is quite wide, and I guess this could some of the challenges that we could be facing. But thinking about integration at service delivery level, I mentioned about integrating provision of these services as they relate to sexual reproductive health might be one angle that we need to capitalize on, or so that we are able to tackle the number of issues, as has been indicated. There are issues of menopause that we are now seeing coming, particularly for countries like Zambia, where the life expectancy is increasing and we are seeing more of these issues coming in. So yeah, I think well said by my colleague, and I wouldn't add any more. But thinking about activism, how do we approach this? Of course, difficult to approach them at the same goal, but taking one at a time, or taking all of them but at different angles, and having different people taking interest in all these aspects of sexual reproductive health. Thank you.
Thank you, Choolwe. We have an interesting question here from Amanda Mason-Jones, where she observes that much of the discussion today has been about lack of physicians in tertiary services in terms of the barriers to access to reproductive health. But how should we think about including nurses and primary care services, school health services, pharmacy services, for example? Françoise and Choolwe, could either of you say more about that?
Well, I think that that's a really important insight, and I can give a couple of examples, at least from a Canadian perspective. One of the barriers, or has shown to be a barrier in Canada, is in fact nursing staff, because if you're having a surgical abortion, nursing staff is very intimately involved in that process. And there are hospitals, because I know I've been called in to offer some assistance in terms of ethical decision making, where the nursing staff refuses to participate. And when I say nursing staff, typically it's individual nurses, so it's not, a group of nurses are boycotting the OR, but specific nurses refuse to be scheduled in that space. And then what happens is other nurses, at least this is the experience I'm aware of, other nurses will pick up those shifts in order to ensure that the service is available. But then at some point they object and say, look, I didn't get into nursing to just do this. There are many other things I wish to do. And for political reasons, I'm finding myself having all of my career in this space, and that's not fair. And so then what happens is we do have to have a conversation about what can be the role of nursing. Now, I've given an example of a way in which they're contributing to being a barrier. There are ways in which they clearly contribute to improving access in terms of information giving and soliciting. With respect to pharmacy in Canada, when we finally had the legalization of medical abortions, we had a number of pharmacists, individuals, who would refuse to fill those prescriptions. And so again, then we saw efforts on the part of some to say, well, I'll take those shifts, or we'll have to have the requests come in at a particular time. And so we have, again, seen challenges from pharmacy, but then we've also seen access. So for example, in Quebec, the pharmacy is in a position that they can actually help prescribe and respond immediately without having to go through the medical system. So I think you're absolutely right to say that there are many parts of the healthcare system that can either contribute to increasing or decreasing access. At least that's the experience in Canada.
Thank you. Choolwe, did you want to offer any comments there, or shall we move on?
Yes, beyond the nurses level or within primary healthcare, I think for settings like here in Zambia, where even within a facility you find limited skilled providers, I think expanding the skill set to community volunteers, that's another controversial issue, because for most of our community volunteers, this is voluntary work they provide. But we have seen that when community volunteers are empowered to provide services, we have seen them do it exceptionally well, but also including peer adolescents who can support within their settings where they feel they do not have the privacy. So yeah, I think I thought I could add that. Thank you.
Thank you. I wanted to raise a couple of questions that have been on my mind that were sort of touched on in how this discussion was framed, although less so directly in the presentations. One, I think, is, I'd mentioned this sort of upsurge of interest worldwide in pronatalism. And I'm really curious to hear from Françoise and Choolwe your take on this, because on the one hand, the pronatalists aren't wrong that demographic decline does pose challenges for certain economies and social contracts built on growth. But on the other hand, of course, it's worth noticing which populations get identified as the problem. And of course, anxiety about falling birth rates is often concentrated in wealthy nations, entangled about, fears about cultural and ethnic composition. I guess I was just curious to hear from both of you, is there any way of disentangling kind of legitimate concerns from the politics of who counts as desirable future citizens? What do both of you make of this global resurgence of interest in pronatalism?
Well, in a Canadian context, we have a scenario whereby we are a federation, and so we have some national policies and we have some provincial policies, and we certainly have seen provinces use the tax system as a way to arguably promote childbearing. But you could argue, quite frankly, well, that's actually really important that the state understand that, the work that happens in families to support young children is costly, and therefore that we should be making a contribution to that. But, you know, we literally had a program called the baby bonuses, right? And so you can think about the ways in which that's meant to encourage people to have children, and especially have more than one children, because of the increments that go with that. You know, at the same time, I think it's important, I think what you were alluding to, which is that we see different communities having different practices around reproduction and the ideal family size. In Canada, we are not replacing ourselves. So in other words, two people are not having two children together. We do have some families that are quite large, but we also have a whole cohort of people that do not appear to wish to have families at all. So are making this new generation, many people are making a decision not to reproduce, or if they do reproduce, to have only one child, so not to replace themselves. That is not true for all communities across Canada, and especially we see higher rates of reproduction amongst our First Nations. And we also have had a very generous immigration policy. And so we do see among certain cultural and ethnic groups different practices with respect to that. I'm not an economist, and I don't understand all of the claims that are being made, but the short one, which is one that I'm moving into, is that those of us who are retiring depend upon younger people who are still working to contribute to our pensions and to contribute to our GDP, et cetera. And so in a way, it seems motivated more by finances and a certain kind of fiscal stability than it does anything to do with embracing a new generation of citizens. So that would be my perspective on this issue. It's complicated, but it is very real. We are not replacing ourselves, and economists and politicians tell us this is a problem.
I think we still don't have Choolwe back for her response to this. I think, Choolwe, I don't believe you're there, that we just have this ghost square.
Well, one other thing I can add just for people to reflect on is that many people will be aware that for some time, long time, China had a one-child policy, and that in this space, they have opened that up to be a two-child policy, but that many people are in fact not embracing that policy change. In other words, it's become normalized in some sense to have one child, but it's just really costly to have more than one child. And also people will know, I think, that there were some gender imbalances that resulted from that policy. So it's a way of also showing how you can introduce policies around reproduction that can have unintended effects.
It strikes me that one of the themes for the conversation today, and this kind of comes back to your point about, you know, access to abortion being in some sense in Canada built on sand or built on a vacuum, that actually there's a necessity for politicians to sort of have the political will to have the deeper ethical conversations with their population to sort of understand, you know, the variety of sort of social views, rather than kind of implement policies without having that deeper sort of principled understanding, because it can mean that policies are out of step with people's opinions, or people's opinions have moved on. So the necessity for that kind of deep consultative dialogic work to happen that politicians don't want us to have anything to do with.
Yeah, well, I mean, in many spheres of my work, I've sort of been a strong advocate of dialogue and consensus building and trying to move forward. But I will say increasingly, I think many people, including myself, have grave concerns about what it would mean to turn over some of these questions right now in a context we are seeing a fair bit of aggression, I would say, around issues that have to do with women, whether it's women in the workplace, women in the home. And I think a lot of people will be aware that there's just a lot more sensitivities now that I'm not sure people are convinced that we could actually have a robust dialogue. So I think that seems more risky now than it might have at another moment in time. So in the abstract and principled, I personally am deeply committed to saying we live in a democracy. We should put these questions to the people. But I will say publicly, and I think it's important, I'm having to rethink a lot of my work, because in my academic lifetime, we have gone from a number of democracies and sort of an upswing in terms of the number of democracies after World War II, and now we're on the downswing. And for those of you who don't know, it is well documented well documented that now less than 50% of the world's population lives in a democracy. So when we have conversations, we can't assume a democracy. And I'm not saying that that's the best or the only way for us to govern ourselves, but it does mean we have to rethink what are the starting assumptions about when government does or doesn't have to consult its people in terms of thinking things through. So I think we're living in a much more complicated time than I think we were, say, 15, 20 years ago.
I mean, to reflect back at you, Françoise, what I hear you to be saying is, though in principle, of course, kind of citizen involvement and consultation should work, there are certain circumstances where that very historical path dependency that we talked about means that a kind of fragile, pragmatic accommodation might be better to stick in place than sort of opening a Pandora's box at a particular moment where it could be mobilized by bad faith actors and so on and so forth, which is, yeah, a very difficult line to tread, of course.
Yeah, I think the way I would frame that right now is we do not live in a period of benevolent governance. And so, and that can capture things like democracies, like kingdoms, like all kinds of things, but you have to have benevolence at the core, that you are actually working for the good of your people. And I just don't think we can have that as an assumption anymore, regardless of the way in which it's formalized as a form of governance.
Look, as we draw towards the end of the conversation, and I just wanted to open up. Actually, there's a really nice question here from one of our attendees, which is, how do Françoise and Choolwe, how do you both foresee the reproductive and sexual health playing out on the broader global health agenda in the coming years? What do we expect to see coming down the pipeline in the medium term?
I would think that we're in for a period of considerable turbulence. I think it's very unfortunate Monica was not able to join us, but I think the decisions made around USAID are significant. And I think we saw the significance of that in the moment that a decision was made to withdraw ongoing funding. There was also a decision to destroy contraceptives that could just as easily at no cost have been distributed. And so from my perspective, that's actually showing a certain kind of meanness. It's one thing for a government to say we've changed our priorities and we are not going to support this kind of activity. In my own view, something that was a very unfortunate decision, but countries can make those kinds of decisions. But I think the next step to actually say we have contraceptives, we'll just give them out and then we're not giving out anymore, to actually say, no, we'd rather spend money to destroy them than to distribute them, I think speaks to me about a period of time that I find concerning, because that's actually talking about virtues and vices as opposed to talking about, policies and, political orientations.
Choolwe, did you want to jump in there? Oh, sorry, my apologies.
I have similar viewpoint. I think the withdrawal, particularly in relation to withdrawal funding, I see that contraception access to services might be, the implication might be more on contraceptive and sexual reproductive health services, particularly for countries like mine, low resource settings where government might need to begin prioritizing on services. So I worry that contraceptives and sexual reproductive health services might be disadvantaged. However, I still think that there's still opportunities. I think we need to rethink, even as countries, thinking about ways that we can survive within the minimal resources. And that might take a lot to rethink, because because these are areas of services that have always traditionally been funded. And so, indeed, the implications might indeed be negative, particularly on reproductive health services.
Choolwe, I thought your framing of this as an opportunity is really interesting, because it gives me an opportunity to raise something that actually came up in a previous brochure panel some time ago, probably about a year now. The global health scholar, Soji Adai, he made this sort of very interesting and somewhat provocative observation about the, as he called it, the opera of outrage over the USAID cuts, as a kind of implicit endorsement of a flawed pre-20, a flawed status quo, and that global health funding has been characterized by what he would call neodependency. Now, of course, this doesn't make the cuts any less devastating in the short term, but I guess it raises the question for me, or at least it did at the time, and I'm curious for your reactions. Sort of, is it possible to mourn the collapse of a system while also acknowledging that the system itself was part of the problem? And what opportunities do you see for reproductive health and reproductive health funding in this new global environment that we're now entering into?
Okay, I hope I got your question well, but I think what I would immediately respond to that is, while we're experiencing this shock, I still think that as governments, we might need to begin rethinking on how we can prioritize these services. Of course, like I indicated, there's been traditionally dependence on funding, but it's time for governments to really sit back and think about how shall we survive and how shall we prioritize some services and to ensure that we do not have drops in the investments that we've made. Thinking about what we have within and trying to spread out the nets with whatever we have, I think might help. But I think it's not a time to mourn, but it's time to rethink on the best ways to move forward.
Thank you. Françoise, did you have any comments in response?
I mean, I think that when I heard those remarks, there's a part of me that goes to sort of, the metaphor we have, important to teach a person to fish, not merely to give them fish, and that, is something that in the abstract I can support. But I do think that there's a different perspective here, which is that when we look at low and middle income countries, they are already hamstrung by all kinds of international policies put out by the International Monetary Fund. They're already borrowing monies in order to provide basic services, whether that's education, whether that's, clean water, et cetera. And so I think it's in a certain sense, it's a bit of a failure to understand that certain things are global problems and that we actually too often assume that they can be solved narrowly within certain geographical borders. And I would say that I think that kind of thinking is in part what led us to what I would describe as the moral failure of our response to COVID. We think that we can solve these problems within our borders for our peoples, whatever that means, and that we can gift some little resources to other parts of the world. And I think it's important not to think about this as gifting. So yes, the example is USAID, but it's really about saying we have huge inequities globally, and we share one planet, and we are one human race, and we need to think differently about our moral obligations. And so I think about this as there are some spaces in which that kind of thinking is important, but it's not about taking away resources. It's about shifting what you would put the resources into. So to ensure that you're building capacity rather than just, delivering, philanthropy. So I think there's an important point there, but I also think that I would want to place this in the scope of everything else that people are entitled to as human citizens. And so you're entitled to access to good health care. And I think reproductive health, as broad as we've been trying to sort of say in response to some of the questions, which goes beyond this, is part of our communal obligation to all citizens of different countries on this one planet.
Thank you so much, Françoise. I apologise to everybody whose questions we weren't able to weave into the discussion. Inevitably, there's always more to discuss. We just begin opening up these big questions when we have to round out. Look, I feel we've covered a lot of ground, from the particularities of Canadian federalism to Zambian supply chains. I'm really struck by Françoise's observation, about the necessity of sort of dealing with the moral challenge of the fact we are not living in a period of benevolent governance, and the sort of tactical and strategic implications that flow from that. But on the other hand, more optimistically, I'm also struck by Choolwe's insistence that even in crisis, there may be opportunities to build something more resilient. So thank you both for your thoughtful and considered contributions. Choolwe, thank you for persisting through the technical challenges, and thanks to all of you for making this such a vibrant discussion. We so appreciate your time and hope you can make another meetup soon.
Great. Thank you, everybody, for signing in, and thank you, Sally, for masterful moderation.
And I should say thank you also to the Brochet Foundation for facilitating this. Oh, Choolwe, I apologise. I cut you off for your final remarks.
Thank you. No, I just wanted to say thank you so much for everyone that signed in and for your patience regarding my tech challenge, but super happy to have been here and been part of this discussion.
Thank you all. Take care.